Dear committee, dear audience, let me present my PhD work. I'm Tímea Lőrincz-Molnár, a pediatrician resident doctor interested in neurology. My aim is to help children and their families dealing with neurological conditions while improving the diagnosis of paroxysmal events in childhood. To achieve our mission, we are differentiating paroxysmal events in childhood using Video-EEG monitoring and patient data. We are using, during our work, the same PECO question framework, the same clinical question, but we are performing two different scientific methodologies, first a systematic review and a meta-analysis, and the registry analysis. Let me start with my first project. As a background, approximately 1% of the pediatric population is affected by epilepsy. But one study shows that nearly half of patients with paroxysmal non-epileptic events are misdiagnosed. These are events that resemble epileptic seizures but do not involve abnormal electrical activity in the brain. The misdiagnosis has severe consequences. First, in case of overdiagnosis, children and their families will face social stigma, the children will have constraints in their daily life, and furthermore, it also means a huge financial burden nationwide. In contrary, in case of underdiagnosis, there is a still untreated underlying condition in case of children, and then can experience several medical conditions. And sadly, the diagnostic delay can exceed beyond even 20 years, having harmful effect on patients' lives. But how can we diagnose paroxysmal events? The current routine diagnostic method consists of patient history taking, neurological examination, and access of home videos where parents capture the suspected event alongside with the EEG investigation. The gold standard method is the long-term continuous Video-EEG monitoring, which requires special medical expertise and equipment, mostly available only limited in epilepsy centers. Therefore, our aim is to characterize the paroxysmal events based on Video-EEG monitoring data to improve the diagnostic routine and to serve as a guiding framework during the assessment of home videos. In order to achieve our mission, we have to answer the next question. What are the Video-EEG and patient history data differences between epileptic seizures and PNA in children? Therefore, we are investigating children with paroxysmal events, we are comparing epilepsy with PNA, and we are working with patient data and Video-EEG characteristics. And we suppose that there are notable differences between the two entities. We did a systematic search using three main databases. Here you can see our search key focusing on the pediatric population, Video-EEG monitoring, and epilepsy or PNA. After the systematic search, we could access 40 eligible articles. We could further subdivide our articles based on the patient's age. We have an infant and toddler subgroup consisting of children data aged between 1 month and 3 years, and the pediatric subgroup containing children aged between 3 and 12 years. During the literature review, we faced more than 340 semiological event types, and based on the Luders classification system, we subdivided them into 28 main semiology event groups, which can be seen on the screen. In total, we accessed 21 articles analyzing more than 1,000 children with epileptic events, and 19 articles accessing nearly 2,000 children with paroxysmal non-epileptic events. And the statistical results resulted nearly 90 plots. As a summary, all our articles were retrospective cohort studies. Our measured outcome was the pooled proportion of children experiencing specific events, and for the indirect comparison, we needed 3 different articles from each group. And let me present my main results. First, the RS semiology is a sudden stop in the activity, as you could see in case of this infant. Based on our results, in the infant and toddler subgroup, this semiology appeared twice more frequently in the epilepsy subgroup, and this difference was also statistically significant. Moving on, the hypermotor semiology, here you can see that it's a hyperkinetic, vigorous activity lasting for several seconds or even minutes. Based on our finding, in case of children's subgroup, this semiology appeared 5 times more frequently in the epilepsy subgroup, and this change was also statistically significant. Our third semiology is the tonic event, which is a sudden stiffness in musculature, as you can see in case of the 10-year-old female patient. And based on our findings, this event occurred even 5 times more frequently in epilepsy, and this difference was also statistically significant. And lastly, the spasm is a sudden muscle contracture, mostly affecting the axial musculature, and unfortunately, we didn't have enough data to do subgroup analysis, but based on our finding, in the 0-21-year subgroup, it appeared 9 times more frequently in epilepsy subgroup, and this difference was also statistically significant. Our work is unique as it's the first comparative study in pediatric neurology. We use a comprehensive methodology and we perform age-specific characterization. But we have to deal with a small amount of articles and due to the lack of direct comparing studies, we cannot perform sensitivity, specificity, and positive predictive value analysis, and we had to deal with different semiology reporting methodologies also. But based on our findings, arrest, tonic, hypermotor, and spasm events are statistically significant indicators of childhood epilepsy, and their assessment can be started by assessing the home videos. But in case of other paroxysmal events without any evidence, children have to undergo proper neurological investigation, accompanied most preferably by Video-EEG monitoring. And in the future, we need further semiology characterization using direct studies with sensitivity, specificity, positive predictive value studies. We really need a uniform semiology reporting system, and this can result in differential diagnostic protocol for differentiation of paroxysmal events in childhood. Here you can see the progress of our manuscript. We are at the internal review phase. And being further interested in the differentiation of paroxysmal events, we are investigating tonic events using our children Video-EEG registry data. The Pediatric Children's Hospital's Video-EEG monitoring unit was established in 2001. Here, children and their families can benefit from continuous video and EEG monitoring, and over the 20 years, there were more than 1,500 recordings with the aim of diagnosis, differential diagnosis, and pre-surgical assessment. Our aim is to differentiate tonic events of epileptic and non-epileptic origin to get aspects that can differentiate these entities. So based on our findings, tonic events are more associated with pediatric epilepsy, supported by statistical evidence. We started our project with the development of the registry analysis plan, focusing on aspects of tonic events such as frequency, duration, or even other accompanied symptoms. After that, we could obtain the ethical approval, and during the patient enrollment, we could enroll more than nearly 400 children aged between 1 month and 21 years. We are now progressing with the data extraction, and we are looking forward for the statistical analysis and article writing phase. To sum up, we are doing these two projects in order to differentiate the paroxysmal events in childhood. Let me finish my presentation with words of Rumi. Every child is a different kind of flower, and all together make this world a beautiful garden. Thank you for your attention.
Thank you for the very interesting presentation. I have just one question regarding the second project, registry analysis. Do you plan also to incorporate data from the magnetic resonance imaging, or it will be only based on the clinical presentation and the video EEGs?
Thank you for your question. We are in a unique situation as we have a huge registry data containing not only electroclinical data on patients examined, but we also have MRI and other radiological investigations too. So we are analyzing that too, and if we have any evidence, then we will focus on that too. Thank you.
Thank you.
Congratulations. I have a question related to your first topic. So when I guess not in most of the hospitals the resources are limited, so not all the children goes to this overnight EEG recording, right? So I think there is a selection process there, and when a diagnosis is not obvious, then it's used more often than in a situation when the diagnosis is easier. So are you not afraid that there is a selection bias there? Because when a patient comes in with an obvious epilepsy, they go immediately to the treatment without this Video-EEG. So what's your opinion on that?
Thank you for this aspect, and I totally agree with you. We had several discussions about this topic, even related to our second project, because if we work in a neurology department, in an EEG department, then we work with expertises, and there is a bias because they are experienced, and in most of the cases there are obvious signs that exclude the epilepsy, and in most of cases with paroxysmal non-epileptic events, even child doesn't get any investigation by monitoring, long-term monitoring. So that's the aspect of this study. Yes, I totally agree with you.
Thank you. And related to this topic, so do you have any data on how many children with the suspected epilepsy go through Video-EEG in other country or in Hungary?
It's a great question. I don't have exact answer for that, but as far as I know, most of the children are admitted or the neurologist try to admit to Video-EEG monitoring when there is an uncertainty whether that's the real epilepsy or whether it's a really rare semiology, in order to investigate in long term to record an event in order to differentiate it based on the electroclinical and video data.
Thank you.
Thank you very much.
Thank you for your presentation. Firstly, I would like to ask about your first project that you recommend for research to have a unified semiology method. Do you have any suggestions will you discuss in your article what would you recommend to do, how to do it?
Yes, thank you for the question. As you could see, we use the Lüders classification. It's the International Leagues Against Epilepsy article that provides a semiology classification system focusing on epileptic patients. And in our work, we propose another classification with 28 semiologies that can be used even in case of epilepsy and paroxysmal non-epileptic events too, and we are discussing that in our article too.
Thank you. And just a general question, that when in these children experiences tonic events, is this scary for them? Do they get angry because of it?
It depends. Most of them can feel or during this experiment, and one of them doesn't remember it. It depends on the individual patients.
I see. Thank you.
Thank you.